I'm Peter Block in Chicago at ACC 2016, and it is the wrap-up of day 2. And we have a special treat. We have 3 amigos here. We've got the wide receiver on the far end, Deepak Bhatt, our major league middle linebacker, and of course, me, Peter Block. So let's go ahead and talk about some trials. Kim, you want to talk about Gauss.
Sure. Gauss 3, very interesting trial. Looked at statin-intolerant patients, retried on statins or placebo, and then a group of patients got either ezetimibe or one of the new PCSK9 inhibitors. My takeaway from Gauss, interesting. First of all, patients who've been intolerant of statins before, 25% of them will be intolerant of placebo. So that's interesting. A lot of us have muscle aches. The other thing is 42% were intolerant of a second trial of atorvastatin. That means more than 50% could take a statin. So this trial really suggests to me that many of these patients who were statin intolerant in the past can take a statin, and if they have very firm indications, we should continue pressing the bar.
Boy, he just talks and talks. So tell me something very quickly. What do you think of this?
Yeah, I agree, but my take on it was a little different because there are folks out there that are saying that statin intolerance isn't real, that it's up by
Exactly.
the PCSK9 inhibitor companies, that they never see statin intolerance. So first of all, I see a lot of statin intolerance in my practice. And I know some of it, it's a placebo or a nocebo type effect. I do get it. But I think this study showed that there are some folks, about 40% of this population, it's the real thing. It's a real myalgia.
You took the wind out of my sails. I was going to say exactly the same thing. So let's move on. Stitches. So Deepak, talk about stitches.
Well, it confirmed what I sort of believed and how I always used to practice and still like to. That is, if you've got, 3 vessel disease and your LV functions down, send them to CABG if you can. It's better than medical therapy. Stitches, it took a few years for that benefit to emerge and be statistically significant, but that's true of a lot of the surgical trials. The benefits never kick in quickly. The morbidity kicks in quickly, but the benefits, it takes a while to accrue. So Jim? I believe it.
I agree. That early hazard was overcome by 10 years. Okay. Significant difference.
Yeah, turns out blood flow is good for the myocardium.
Yeah, who would have guessed?
Yeah, what a surprise.
That is shocking.
All right. So we have another trial here, the 2-year surgical outcomes of moderate mitral regurgitation. I'm going to take a hit at that. It's actually an interesting trial in that it shows that at 2 years, patients who had bypass graft surgery end up having better mitral regurgitation, not reduction necessarily, but maintenance, and their ejection fractions improve. The only thing I take away from this trial is that if you do a coronary bypass graft circulation to the posterior circulation, to the papillary muscle, you basically do the heart a lot of good. And remodeling, in fact, improves. So doing a CABG with mitral regurgitation, reducing the mitral regurgitation at the same time, actually is a good operation.
Yeah, but there's an early stroke risk there, right?
There is, but there's a stroke risk for operation, period. I think the long term, the real issue here is that the ventricle gets better. That's pretty impressive. All right, let's move on. There's a third trial about patient involvement in making the decision to leave the ER. Kim, you got to take this one on.
Yeah, it was a very interesting trial. 900 patients randomized to be very involved in their decision making in the emergency department or usual care. And the study clearly showed that if you involve patients in thinking about their risks, they like it, they're more knowledgeable, and in general for lowest patients there's less testing and less admission to the hospital without any untoward safety signals. So informed decision making is here. Patients and families want to be involved, and the chest pain centers in our country are a very good place to start.
Okay, I think there's a lot of people out there who's going to say this is all touchy-feely stuff and makes no difference, but I will tell you something. Quality metrics are here to stay, and whether we like it or not, that's the kind of thing that involves patients and improves quality.
Well, accountable care organizations are also here to stay, and this sort of approach, keeping patients out of the hospital, keeping them from getting a bunch of tests that we maybe don't really believe in getting, but we feel sort of medical legally obligated to get. If the patient's saying, look, I don't want that unnecessary stress test, it makes it easier to say, yeah, you really don't need it.
Yeah, it's all good. All right, let's move on. Accelerate. Deepak, you wanted to say something about Accelerate.
Well, I thought it was an interesting study. Sometimes people say, oh, it's a negative study, so ho-hum, so what? But I think it's interesting because it showed this compound which raised HDL, didn't reduce ischemic events. And okay, we already sort of know that HDL hypothesis, it's hurting, but But the interesting thing is this drug lowers LDL by a lot too, and there was still no reduction in ischemic events. So it does make you wonder whether LDL reduction in and of itself is sufficient to reduce clinical events, or the mechanism matters. And I think it is that the mechanism matters.
It really does drive this notion that we don't understand the mechanisms related to HDL and LDL lowering as they relate to events. And this trial, once again, just confuses me on mechanisms, Deepak.
Yeah, I think it sort of boils down to you need large outcome trials to sort these things out. Sometimes the biology makes sense, but we don't really understand biology as well as we think we do.
I think we haven't got a clue if you really wanted to.
I think you're right.
Yeah. Okay, so the last one is mobile health. This whole business of having a pedometer and getting people at your workplace to make you walk around a little bit more, turns out those patients really do pretty well. Kim, you're the big guy that wants to do preventive medicine. Talk to me about this.
I love this trial. It's not a randomized trial, but 60,000 patients getting mobile health advice, using pedometers in teams in their workplace, losing weight, increasing their steps, eating better. It really does suggest that a low-cost platform, mobile health and pedometers, can have a difference in global health. And I was very excited about this outcome. I think it's the future of mobile health, and how we use it in chronic disease and preventive disease. We're just scratching the surface.
Yeah, I agree. I think it was very exciting. I mean, I do think we need to be rigorous in terms of examining apps and things like that. Not everything out there, is necessarily a winner, but this particular approach makes a lot of sense.
Okay, so that's the end of the wrap up. So for everybody out there, get a pedometer, walk around, and make sure you're mobile.